These are all the studies that look at it, and I'll highlight with the next one. This is very busy, but I want to highlight a few things. I think the first thing to look at is circling this, is the number of women involved. If you can imagine these days, it's very hard to do these kind of trials anymore, because if I said to most women in this group, we have something that we think is good, you'd either want it or not want it. And so research is very different these days than it used to be. But we have all these women to thank for where we are today. And if you look, continue on, when we look at all of these different trials, what's interesting is if you look at the sensitivity, so going back to what sensitivity is, it means of those women who ended up having breast cancers, how many of them were found on that mammogram. And in multiple different studies, it ranged from as low as 70%, which isn't great, to as high as 98%. So a lot of these trials suggest that this is a good tool and should be still considered. Again, there are times when it's not going to be successful. Continuing on, if we look at how specific it is, this is really important. We're not telling people that they have breast cancer when they actually have something else. It's very, very highly specific, and I think that is a very important thing as well. And finally, what's this positive predictive value? Again, if we get an abnormal mammogram, you want to know how likely it is when you get a biopsy or any type of imaging or colonoscopy or anything. How likely is it if there's something is seen? What is the likelihood that it's cancer? By workup method, what they mean is if you're asked to have additional x-rays, only about 10% of the time will you actually end up having cancer. And that's kind of comforting to hear. With the biopsy, it varies significantly, and the range that we think it should be in is about 25 to 30%. And I know that seems sometimes low to some women, it seems high to others, because they feel we should be better at being able to pick up cancer and not biopsy all those others. But if you get too high, it means that you're probably missing some cancers when you're looking at it. So this is a very important aspect of it. And these come from trials, again, that started in the 1960s. So clearly, we have some reservations about how they were done and the quality of the mammography, but it is important to think of them as our history. So going on, all of these showed, if you look at this scale, so the way that this looks is if you look at 1, that would be a group of women and their risk of dying. To the left, if you do mammography, you have less of a risk of dying from breast cancer. To the right, you would have more. And these are all the trials that look at it. And what you clearly see is there's at least a 25% reduction in mortality by doing mammography on a regular basis. And again, as I put down at the bottom, the disclaimer, it doesn't account for poor mammography, lack of actual screening. And what I mean by that is if you actually look at these trials, sometimes only 60% of the women actually went for their mammography, and yet they still did better than the other group. And then time interval I bring up because, and we'll talk about that under controversies, because time interval could vary in these trials from as short as a year, which is typically what the guidelines are that I believe in, and we'll go over that. And it could be as long as 2 or 3 years in some of them. So continuing on. So one of the ways that there's a Swedish researcher, Laszlo Tabar, who has done a huge amount of research in this. And one of the benefits of the Swedish system is that when you are born, you are registered, you get a number, and you are followed for the rest of your life. If you have a medical problem, everybody knows about it. It can be looked at. So a lot of the Swedish and Danish studies really, really have good follow-up. And what they tried to do is, when there was an argument that the reason that there's a higher survival is we had better treatments now. It's not that we found it earlier. It's not that the mammography made a difference. And so what they did was they took 2 completely different time periods. Very early on, basically from 1968 to 1970, when there was really no treatment for breast cancer other than radiation, and then looked at a later time period. And they say, okay, we'll take 2 groups of women. And there are still women in Sweden during that time who were not getting screened on a regular basis. So if you look at the top curve, what they're saying is these are all women in the new era who've been screened and gotten more treatment. But compared to them, if you look at that open triangle, those are women in the same era, in the 70s and 80s, who develop breast cancer got the same treatment but still have a lower survival. It's not as clear in the distant past because, again, when you look at those women weren't really getting as effective treatment. But in the new era, it really does make a difference to find it early because of the treatments that exist. And so this was a very elegant way of looking at it. One other argument that suggests that this really has made a difference is if you look at this, in the early 1990s, this is when mammography was approved by Medicare. And why that's important is that most insurance companies will then follow suit. So when Medicare says this is an acceptable type of a treatment, then or test, the other insurance companies follow. So it was really not until the late 80s and 1990s that it was approved to have mammography on a regular basis. And as soon as that happened, you start to see a decrease in mortality from breast cancer. It's the pink line and it goes down. So since that time, we've had almost a 30% reduction. And that's just the only thing that we can say. Treatments have improved to some extent, but in addition, mammography has improved and the number of women who get mammograms on a regular basis has improved. So let's look at the guidelines now. American Cancer Society, I'm going to give you two sets of guidelines because there are many, but most medical organizations follow the American Cancer Society guidelines. So if you look at the American College of Surgeons, the American College of Obstetrics and Gynecology, the American College of Radiology, these are the guidelines that are used. So still baseline mammogram at 40, and we'll talk a little bit more about why we choose 40 and who should get it before 40. A yearly mammogram as long as you're in good health. Obviously, if you are 76 and have multiple other medical problems, getting a mammogram and finding a 5-millimeter cancer is not going to make a difference. But if you're in good health, you should continue to do it. Clinical breast examination, and this can just be by any healthcare provider who feels comfortable doing it, yearly starting at age 40. And then even before that, from the age of 20 to 40, at least every 3 years, you should be having a breast examination. And the reason they made it every 3 years is, again, because of the low incidence of cancer in that age group, but also because we know that women now, the screening with pap smears has changed to every 3 years, so many women aren't going to their gynecologist more regularly, and so we're hoping that by emphasizing it, it emphasizes to gynecologists to do this examination. So if this is the guidelines, where does the controversy come? So what the controversy comes from is this task force that put out some information in 2009, and it made a big splash. It came out, of course, in October for Breast Cancer Awareness Month, and this is a group of basically scientists. They took recommendations from physicians, and then they looked over them, did some mathematical modeling, and said, here are our recommendations. So basically what this Preventive Service Task Force came out in their recommendations was they recommended against routine screening for the 40 to 49-year-old. They said you can discuss it with your physician, but they're recommending against it. Which the concern about that is if you spoke to a physician, I'm sure that they would recommend the mammogram. The problem is whether the insurance companies are then going to say, we don't have to cover it. They recommend only biannual screening, so once every 2 years from 50 to 74. And then they don't make any recommendations about women over the age of 74. They said there just isn't enough data, and they weren't going to make a recommendation, which again worries everybody because what does that mean for the Medicare population? And of course, the last thing they said was don't even worry about breast self-examination. And so this came down after they looked at the medical data. So let's look at some of that information. So continue on. No, this is okay. You know what? Well, I'll look at this is important because what I was saying before is, you can go back. Sorry. They used different models. What they tried to do was use various mathematical models to look at this. When they talk, and so they're looking at benefits and they're looking at harms. And so the harms that they looked at were obviously extra anxiety created by additional evaluation, need for biopsies, and what they call overdiagnosis, and I'll explain a little bit more about that as we go along. What they consider is what's called efficiency. If we take a group of women, how efficient are we at screening them? How good is this? And it's really a cost-benefit analysis.